Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Have you ever been told that your self-identified race, maybe your ethnicity, might directly influence which blood pressure medication is going to work best for you?
It's a really long-held belief in medicine.
Yeah, and honestly, for decades, it's shaped how we treat, well, one of the biggest global health challenges out there. So today, we're confronting that belief head-on.
Hypertension, high blood pressure. It's not just a number on a cuff, is it? It's this silent epidemic affecting people across all ages, and it's a leading risk factor for really devastating conditions like heart failure, stroke, kidney disease.
Right.
And here's the kicker. Despite having this whole arsenal of effective drugs, blood pressure control rates worldwide are often, well, surprisingly low, frustratingly low.
So our mission in this deep dive is really to unearth why. Why is there such vast variability in how people respond to these medications?
It's exactly.
And we're going to fundamentally challenge the long-standing use of race-based guidelines in treatment.
What you're about to hear, it synthesizes insights from landmark clinical trials, some cutting-edge genetic research, and critically, these deep dives into the social and environmental factors that truly drive health outcomes.
That's the key, isn't it?
Yeah, because while we absolutely see observed differences, at a population level in drug response, we're going to show you that race itself, it's just scientifically imprecise. And frankly, ethically problematic as a proxy for what's really a much more complex interplay. We're talking genetic ancestry, environmental pressures, and crucially, these social determinants of health.
So this deep dive is going to challenge you, the listener, to think differently about how medicine approaches individual care. It forces us to ask, are we really seeing the full picture here?
Okay, so let's maybe unpack this by setting the stage first. How exactly is hypertension managed today? I know you mentioned there's been a significant shift in diagnostic criteria, especially in the U.S.
Yeah, what's the biggest takeaway there?
I think the biggest takeaway for you listening is that the 2017 guidelines from the ACHA, the American College of Cardiology and American Heart Association, they really lowered the bar.
Lowered the bar how?
Well, what might have once been considered just elevated blood pressure could now be classified as stage 1 hypertension.
Ah, okay.
It's definitely a more aggressive classification compared to, say, the 2023 European Society of Hypertension guidelines, the ESH ones.
Right.
They keep a higher diagnostic threshold.
So more people diagnosed earlier, basically. In the U.S., at least.
Exactly. It brings many more people into that diagnostic fold much sooner.
And it's not just diagnosis, right? The treatment goals shifted too, the ACHA ones.
That's right. They recommend a pretty aggressive treatment goal, aiming for less than 130 over 80 millimillar Hg for most adults.
Especially if you have other conditions.
Especially if you're already living with cardiovascular disease, kidney disease, or diabetes.
Yeah.
It's a clear push for earlier, more intensive intervention.
But okay, before we even get to the drugs.
Yeah.
The lifestyle stuff, that's still number one, right?
Yeah. Absolutely critical. Foundational, really. These non-pharmacologic interventions, we're talking lifestyle modifications, they are universally recommended first.
Like what, specifically?
Things like weight loss, adopting a heart-healthy diet like the DISH diet.
I've heard of BAH.
Yeah, cutting back on sodium, getting regular physical activity. And look, to give you a concrete example, the DAH diet alone, it can lower your systolic blood pressure by about 11 millimeter Hg.
Wow, 11 points just from diet.
Just from diet. That's as good as some medications.
That's a huge impact.
Right.
Okay, so lifestyle first. But for many patients, especially maybe those with stage 2 hypertension, medications become necessary.
Right.
And here's where we've seen a shift. You mentioned doctors using combination therapy more often right from the start.
Yes, particularly when blood pressure is significantly above target. It's definitely a departure from the older, try one drug, see what happens, then maybe add another approach.
And what's the logic there?
Well, what's often overlooked, and this is fascinating, is that adding a second drug, one that works in a complementary way, often smooths out or even completely negates some of those differences in response you might see with just one drug alone.
Okay. That's a really important point for later, I bet.
It's crucial to remember as we dive into some of the historical trials, yeah.
So when we talk about the actual medications, the pharmacologic therapy, What are the main classes we're using? And what's important to know about how they work, especially thinking about our topic today?
Okay, broadly, we have a few key players. First up, diuretics. Specifically, the thiazide type ones, like chlorthalidone.
The water pills?
Kind of, yeah.
Yeah.
Think of them as helping your body's plumbing. They work in your kidneys to help you flush out excess salt and water. That reduces the overall volume of blood circulating, brings down the pressure.
Okay.
And here's a detail that often gets missed. Chlorthalidone is actually like 1.5 to 2 times more potent than the more common one, hydrochlorothiazide or HCTZ.
What does that matter?
It's vital for interpreting older studies correctly because they often use different diuretics.
Got it. Okay, what's next?
Then there are the RAS inhibitors. They target the renin-angiotensin-aldosterone system.
That's a mouthful.
It is, but it's a powerful hormonal system controlling blood pressure. This class includes ACE inhibitors like lisinopril and ARBs like losartan.
How do they work?
Both basically work to relax your blood vessels, make it easier for blood to flow through. ACE inhibitors block an enzyme, ARBs block a receptor, but the end result is similar.
Okay, relaxing blood vessels. Makes sense.
Next up, calcium channel blockers, CCBs, like amlodipine. These are essentially smooth muscle relaxers for your blood vessels too, but they work differently.
How so?
They block calcium from entering the muscle cells in the vessel walls. Less calcium means the vessels widen, resistance drops, pressure drops.
Okay, diuretics, RAS inhibitors, CCBs, anything else major?
And finally, beta-adrenergic blockers, or beta blockers. Metoprolol is a common one.
Right.
Now, these aren't usually first line just for high blood pressure alone anymore.
But they're important for other things.
Absolute lifesavers for patients with other heart conditions, like heart failure or after a heart attack. They work by slowing your heart rate down and reducing how forcefully it contracts. Gives the heart a bit of a break.
Makes sense. So, 4 main classes.
Yeah.
But they all have side effects, right?
Oh, absolutely. And understanding those is key. Every drug comes with a potential side effect profile. Diuretics might cause low potassium, for example.
And ACE inhibitors. The cough.
Infamous for a dry cough in some people, yeah. And CCBs can sometimes lead to swollen ankles, peripheral edema.
So finding the right fit is crucial.
Exactly. Finding the right fit for you, the individual. But that whole idea of finding the right fit gets profoundly complicated when we look at the stark, persistent disparities in hypertension across different populations.
And those disparities, that's where this discussion really deepens, isn't it? Because for decades, certain populations have carried this really unequal burden of hypertension, particularly here in the U.S.
It's a truly significant area, yeah. Individuals of African ancestry, often identified as Black in studies, they undeniably bear the heaviest burden.
How heavy?
Well, their prevalence rates can be as high as 45% to nearly 60%. Plus, it tends to start earlier in life, be more severe, and carry a dramatically increased risk of that devastating end organ damage we talked about.
Can you put some numbers on that?
Yeah, I mean, look at this. Black Americans face roughly a 30% higher risk of fatal stroke, a 50% higher risk of cardiovascular disease-related mortality, and more than 4 times the risk of end-stage renal disease, ESRD, compared to white Americans.
4 times.
And their hypertension-related mortality rate, it's 4 to 5 times greater. These are not small differences. These are massive disparities.
And it's not even uniform within these broad categories. Right?
Yeah.
That's what I found so illuminating. Like, among Hispanic or Latinx populations.
Huge heterogeneity, exactly. Hypertension probability is substantially higher in individuals of Caribbean heritage. Think Cuban at 27%, Dominican at 28% compared to those of Mexican heritage, around 18%.
That's a massive difference within one group labeled Hispanic. Doesn't that alone just fundamentally challenge how useful these monolithic labels really are in a clinic?
Absolutely. It's precisely the kind of data that should make us question decades of practice. It's such a stark reminder that race as a label often masks far more than it reveals about someone's actual biology or their true risk factors.
And we see similar things in Asian American populations.
Very diverse group, too. Prevalence differs: Korean around 23%, Vietnamese 23%, versus Chinese around 13%. And even when prevalence is similar to white adults, they often have lower awareness and poorer control.
So this vast heterogeneity within these broad racial categories, it just screams that using these labels for clinical decisions is, well, scientifically shaky.
Fundamentally shaky, yeah. It challenges the validity.
So if race itself is masking so much variability, what's really driving these huge disparities we see?
Okay, this leads us to a critical pivot point in the discussion. Attributing these disparities solely to biology, to race, it just ignores the powerful, often overwhelming role of social and environmental factors.
Right. Race is a social construct.
Exactly. It's a social construct, not a biological reality, and its correlation with health outcomes. That's largely a reflection of systemic inequities, not some innate genetic difference.
So what does this actually look like? How do these social factors play out?
While unequal healthcare access and insurance are major drivers, just think about the numbers. Hispanic adults, 26.5% uninsured rate. Black adults, 15%, compared to 9% for white adults.
That directly impacts getting diagnosed and treated consistently.
Directly. Creates huge barriers. And then socioeconomic factors in the environment play a massive role, too. Lower income, less education, food insecurity, they're all tightly linked to higher hypertension prevalence.
You mentioned food deserts.
Yeah, and certain dietary patterns, like the so-called Southern diet, particularly prevalent among Black Americans. These aren't genetic things, they're environmental and social factors acting as major mediators of risk. They create this landscape of health challenges.
And there was that point about acculturation and stress that was really striking.
It's incredibly striking. Look at foreign-born Black adults versus U.S.-born Black adults. The foreign-born group has a dramatically lower hypertension prevalence, around 27%, compared to 42% for U.S.-born.
42%. That's a huge gap within the same broad ancestral group.
Massive. And it cannot be explained by genetics alone. It points squarely to environmental factors experienced in the U.S. Maybe adverse dietary changes, definitely increased psychosocial stress, and the chronic physiological strain from experiencing systemic racism.
Wow. Is there data on how long someone lives here?
Yes, and it's powerful. Each decade of residence in the U.S. is associated with about a 10% increased risk of developing hypertension for foreign-born individuals.
10% per decade.
It just powerfully illustrates that these social determinants of health, SDOH, are dominant drivers, not some inherent racial difference.
Okay, so given how powerfully these SDOH seem to drive disparities, it really begs the question, how do we reinterpret those big landmark clinical trials, the ones that actually informed race-based guidelines for decades?
We absolutely need to look at them with fresh eyes. Exactly.
The first big one we have to critically re-examine is the ALLHAT trial. That's the Antihypertensive and Lipid-Lowering Treatment to Prevent Heart Attack trial.
Huge study, massive, randomized, double-blind, over 42,000 high-risk patients. Importantly, about 35% self-identified as Black, 19% as Hispanic.
And what was it comparing?
It compared a calcium channel blocker, an AC inhibitor, or an older drug called an alpha blocker against a thiazide-type diuretic, chlorthalidone, as the baseline. A really major undertaking.
And the findings in Black participants, they were influential.
Profoundly influential at the time. What they found was that initial monotherapy, just one drug with the ACE inhibitor lisinopril, resulted in significantly less potent blood pressure reduction compared to the diuretic chlorthalidone.
How much less?
We're talking about approximately 4 points systolic, 1 point diastolic greater reduction with chlorthalidone over 4 years.
Okay, a measurable difference. Did it translate to outcomes?
It did, and this was the big one. This difference correlated with a 40% higher risk of stroke for Black participants on lisinopril compared to chlorthalidone.
40%, wow.
Yeah, and chlorthalidone was also superior in preventing new cases of heart failure, particularly in that Black subgroup.
So you can see how those findings became a cornerstone for race-informed prescribing.
Absolutely. It seemed to clearly favor diuretics or CCBs as the first choice for initial therapy in Black patients.
But then came AASK, the African-American study of kidney disease and hypertension.
Right. And ASAC was different. It was specifically designed to find the best drug class and the best blood pressure target to slow down kidney disease progression. And it focused exclusively on about 1,100 Black individuals who already had hypertensive chronic kidney disease.
So a specific population with a specific problem. What did ASK find?
Well, ASK produced some really interesting findings that directly challenged just a simplistic reading of ALLHAT. It found that the ACE inhibitor, ramipril, was actually significantly more effective at preserving kidney function than both a beta blocker and a CCB.
More effective.
Yeah.
Even though ALLHAT suggested ACE inhibitors were less effective for BP and stroke in Black patients overall.
Exactly. Compared to the CCB amlodipine, ramipril reduced the risk of kidney progression or death by a remarkable 38%.
38% is huge in kidney disease.
It's massive. In fact, the amlodipine arm of the study was even stopped early because the renal outcomes were worse.
So what's the nuance here? Why the different result?
Here's the crucial nuance. ASK showed that the benefit of the ACE inhibitor was particularly strong in patients who had significant protein in their urine proteinuria. For those patients, intensive blood pressure control also led to a 27% risk reduction.
So it wasn't just Black patients. It was Black patients with proteinuric kidney disease.
Precisely. ASK firmly established ACE inhibitors as superior first-line agents for protecting the kidneys in that specific group. It highlighted that specific comorbidities, like having kidney disease with proteinuria, provide much more precise indications for treatment than broad racial categories ever could.
So ALLHAT points one way for general primary prevention, maybe, but ASK points another way for a specific high-risk group with kidney disease. It sounds like medicine was kind of wrestling with its own race-based assumptions even then.
Absolutely. And this is where the nuance became absolutely critical. It wasn't about one simple answer for all Black patients. It was about defining the specific clinical context that mattered most. Like, do they have kidney disease? Do they have proteinuria?
How did the guidelines handle this apparent contradiction?
Well, this struggle to reconcile these findings led to updated guidelines, like the 2010 IASB consensus statement. They tried to synthesize both ALLHAT and AASK. They recommended diuretics or CCBs for primary prevention, sort of following ALLHAT. But, and this is crucial, they also emphasized that most patients, regardless of race, eventually need combination therapy to reach their goal.
Okay, so combination therapy becomes key.
Yes, and they explicitly recommended starting with 2 drugs if blood pressure was significantly above goal. And importantly, they incorporated ASK's findings by saying you should include a ARFIS blocker, like an ACE inhibitor, or ARB if there's a compelling indication, like chronic kidney disease.
So even the race-informed guidelines started building in individual factors.
Exactly. This multi-step algorithm reveals that even the guidelines framed around race ultimately relied on individual risk stratification and comorbidities. It demonstrates that a sophisticated, individualized assessment is always superior to a simple one-size-fits-all race choice.
This really leads us perfectly into the genetics, doesn't it? The genetic architecture of how people respond to these drugs.
It does. We know hypertension itself is complex. Genetic factors contribute significantly. Estimates range from maybe 30% up to 55% of the variation we see in blood pressure levels between people.
And that genetic influence extends to drug response, too.
Directly. It doesn't just stop at whether you develop hypertension. It affects how well you'll respond to a specific medication.
Okay, let's unpack that. The field is called Pharmacogenomics, or PGX.
Right, PGX. Essentially, it's the study of how tiny variations in your genes influence how your body handles medications.
How does that work?
Well, it happens in 2 main ways. Through pharmacokinetics, that's basically what your body does to the drug. How it absorbs it, distributes it, metabolizes it, excretes it. Think about liver enzymes like the CYP450 system.
Okay, body acting on the drug. And the other way?
Pharmacodynamics. That's what the drug does to your body, how it interacts with its specific targets like receptors or ion channels.
Got it. Can you give some concrete examples? How does this actually play out with blood pressure meds?
Sure. What's truly fascinating are the specific measurable gene-drug links. For instance, with diuretics like HCTZ, we found that subtle variations in genes like ADD1 can actually predict response. One version of ADD1 is linked to getting a better blood pressure reduction with HCTZ.
So it's not about race, it's about that specific gene variant.
Exactly. It's a specific, measurable genetic difference. Or take beta blockers. There are variations, polymorphisms, in the ADRB1 gene. That gene codes for the beta-1 receptor, the drug's target on the heart.
Like the lock and key you mentioned earlier.
Precisely. Different versions of the lock might fit the key better or worse. Plus, there are enzymes like CYP2D6 that metabolize beta blockers. Variations there means some people are poor metabolizers, some are ultra-rapid, and dosages might need adjusting based on their specific CYP2D6 profile.
Okay, so genetics affects the target and how the drug is processed.
Yeah.
What about the RAA inhibitors?
For RAAS inhibitors like ACE inhibitors and ARBs, well, an older genetic marker, the ACE insertion-deletion polymorphism, hasn't really panned out as consistently useful.
Okay.
But other variants, like in a gene called NOS3, have shown some association with how well these drugs work for certain individuals. Research is ongoing there.
And then the calcium channel blockers, TCBs.
Yes. This is a really powerful example that shows how genetics can explain population-level differences much more precisely than race. For CCBs, Variants in a gene called CYP3A5 are incredibly important.
CYP3A5. What does it do?
It's another one of those metabolizing enzymes. Now, there's a version, the CYP3A51 allele, that leads to faster metabolism of many drugs, including some CCDs. This functional, fast metabolizing allele is quite common in populations with recent African ancestry, found in about 70% of individuals.
Okay, common in African ancestry groups. What about European ancestry?
It's the opposite. The non-functional version, the 3 allele, is highly prevalent in Europeans, over 85%.
So what does that mean for CCB response?
It means individuals who have that functional CYP3A51 allele will metabolize these CCBs faster. Their body breaks the drug down more quickly, potentially leading to lower drug levels and maybe a reduced blood pressure response from the standard dose.
Wow, that's a clear, measurable biological mechanism, not just a vague racial category.
Exactly. It's far more precise. And this kind of finding highlights the big shift we've seen in genetic research. We moved from early candidate gene studies, which often gave inconsistent results, to much larger, more powerful genome-wide association studies, or GWAS.
What did GWAS tell us overall about drug response?
The key takeaway from GWAS is that drug response is highly complex, it's polygenic.
Meaning many genes are involved?
Many genes, each contributing a small effect. This confirms there's a widespread genetic basis for drug response, but it also decisively shows that a simple single gene test isn't the whole story, and certainly a broad racial category is a very poor predictor. It reinforces the absolute need for more sophisticated, personalized tools.
Which brings us right back to this crucial, really ethical imperative. Deconstructing the very idea of race in clinical practice.
Yes, because modern genomic research, things like the Human Genome Project, have definitively shown us that human genetic variation is continuous. It's clinal.
Meaning it changes gradually across geography.
Exactly. And crucially, there's actually more genetic diversity within any socially defined racial group than there is between different groups.
The biological concept is just flawed.
Deeply flawed. Race is a social and political construct, not a biological reality.
And we can't ignore the history here, can we? The historical context is pretty dark.
It's incredibly dark. The origins of using race in medicine are often tangled up with attempts to rationalize horrific things like slavery, and later it manifested in abuses like the Tuskegee syphilis study.
That wasn't that long ago.
No, and this isn't just ancient history, it casts a long shadow. It fuels a profound and honestly understandable mistrust in healthcare systems, particularly among marginalized communities.
And using race in medicine today, even with good intentions, it can cause real measurable harm, can't it?
Absolutely. A clear, really damning example is the use of race correction in formulas estimating kidney function, the EGFR.
How did that work? Or rather, not work?
These formulas systematically assigned higher kidney function scores to patients identified as Black based on flawed assumptions about muscle mass.
What was the result of that?
It led to underdiagnosis of kidney disease, delayed referrals to specialists, and tragically reduced eligibility for life-saving kidney transplantation for Black patients. It's a direct, undeniable example of harm caused by embedding race into a clinical algorithm.
Just devastating.
Beyond such direct harms, race is simply a poor proxy for the true biological drivers. We should be looking at things like salt sensitivity, plasma renin activity, those specific pharmacogenomic profiles we discussed.
And the social factors.
And absolutely, the socioeconomic status and environmental exposures. Relying on race can encourage what some call clinical inertia. It discourages the deeper, individualized investigation that's really needed.
It's interesting how U.S. guidelines often explicitly included race.
Right, like JNC8 and IASHIB.
While European guidelines generally haven't, is that right?
Largely, yes. European guidelines have historically tended to attribute differences in prevalence or response more to underlying pathophysiological characteristics or maybe environmental factors rather than explicit racial categories.
So the paradigm needs to shift.
Right.
But not to being race blind. Right, because that ignores the disparities.
Exactly. We don't want to be race blind because that ignores the very real, pressing disparities driven by systemic factors. The goal is to be precision-driven and race-conscious.
What does race-conscious mean in this context?
It means acknowledging that racism, not race itself, is a key risk factor for poor health outcomes. It means actively working to address those social determinants of health within our healthcare systems and society.
And the precision-driven part.
That means pivoting to using precise biological markers when appropriate, things like genetic ancestry information or direct testing for specific pharmacogenomic variants. and grounding our decisions firmly in the individual patient's unique comorbidities and their measurable physiological traits.
So we could think of it as maybe 3 interconnected pillars for truly personalized hypertension management.
I like that. 3 pillars. What's the first?
Okay, first, genomic precision. Using that actionable pharmacogenomic data we talked about, maybe from genes like ADRB1, CYP2D6, CYP3A5, to help guide specific drug selection and dosing for you, the individual.
Makes sense. Pillar 2.
Second, clinical precision. Basing decisions on your unique clinical context. What other medical conditions do you have? CKD, heart failure. What's your measurable physiology, like maybe plasma renin levels if relevant? It's about your specific health profile, not a broad group average.
Okay. Genomics, clinical picture. What's the third?
And third, arguably the most overlooked, but maybe most important, social precision. This means actively assessing and then addressing those crucial social determinants of health.
Things like healthcare access, food security.
Exactly. Financial strain, housing instability, the chronic stress of experiencing systemic racism. All the things that profoundly impact your risk and your ability to actually achieve blood pressure control.
It's about looking at the whole person in their whole environment, not just their biology in isolation.
Precisely. So this integrated vision, it sounds great, but what does the future actually hold for this kind of truly personalized hypertension management? It's not standard practice yet, is it?
No, not widespread. While the promise, especially of pharmacogenomics, is immense, there are still some significant barriers to actually implementing it broadly in the clinic.
Like what? What are the main hurdles?
Well, one major one is the evidence and education gap. We still need more large-scale, randomized controlled trials that definitively prove that using PGX guidance actually improves patient outcomes in a cost-effective way.
And doctors need to know how to use it.
Exactly. Many clinicians simply lack the training or confidence to order these complex genetic tests and then interpret the results meaningfully for their patients. There's a big educational need.
What about cost? Genetic testing sounds expensive.
Costs and reimbursement are definitely major hurdles, yeah. The testing itself can have a significant upfront cost, and insurance coverage is often inconsistent or lacking altogether.
So it's hard to justify if the cost effectiveness isn't proven yet.
It's a tough sell for healthcare systems and payers, absolutely.
Are there practical challenges too? Like technically?
Oh, yes. The logistics and infrastructure required are substantial. Think about integrating complex genetic data seamlessly into existing electronic health records, which are often already clunky.
Right.
And then creating user-friendly clinical decision support tools, alerts, or guidance that pop up right when the doctor's prescribing that actually help them use the genetic info effectively at the point of care. That's a huge technological and workflow challenge.
So quite a few obstacles. What needs to happen to move this forward then? What should research focus on?
Well, first and foremost, future research must prioritize ancestral diversity in study populations.
Why is that so critical?
We need trials that actively recruit truly diverse cohorts, not just token representation. This is essential to ensure the findings are actually generalizable to everyone, and also to discover new genetic variants that might be particularly relevant to currently underrepresented groups. It's fundamentally an issue of equity in scientific discovery.
Makes sense. What else?
We also need to integrate different types of data much more effectively, go beyond just single genes or even panels of genes. Think about polygenic risk scores, which combine the effects of many variants.
And other omics.
Yes. Integrate other biological data, proteomics, metabolomics, but critically, also integrate rigorously collected data on social determinants of health. We need to analyze how all these factors, genetic, biological, social, interact to determine risk and response, get the whole picture.
And practically speaking, how do we get this into clinics?
That's where implementation science comes in. There's a pressing need for more research focused specifically on how to implement this. Studies looking at the real-world impact of PGX-guided therapy on things like clinic workflow, actual patient outcomes, medication adherence, overall costs.
So figuring out the how-to is just as important as the what.
Absolutely. We need that practical evidence base to build confidence and guide widespread adoption, ensuring these scientific advancements actually reach the people who stand to benefit most.
Okay, so wrapping this up, this deep dive has really shown, I think, why relying on race to guide blood pressure treatment is, well, scientifically flawed at best and ethically problematic at worst.
Definitely. The true picture is just so much more complex. It involves this intricate interplay of genetics, yes, but also individual physiology and these profound social factors that shape our lives and health.
We've seen that those observed population-level differences in drug response, they're real, But they aren't some simple biological destiny tied to these broad racial categories we use.
Not at all. They're more like a complex tapestry, woven from threads of precise genetic ancestry, individual pathophysiology, and the often overwhelming influence of social and environmental factors, the SDOH.
So as you, our listener, go about your day, maybe consider this. How might this shift, this move away from broad, often misleading categories towards truly personalized care? Care that integrates genomic, clinical, and social precision. How might that fundamentally change things?
Not just how we treat high blood pressure.
Right, but how we think about health and equity in medicine as a whole. What responsibility do our health systems, and maybe even us as individuals, have in advocating for this integrated future? A future where care is truly tailored. Well, truly tailored to you.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.